Hello and welcome. We'll be talking today about understanding countertransference and recognizing therapist emotional blind spots. And whether you're a psychiatric nurse or any other mental health practitioner, today we're going to talk about this countertransference, and the talk is designed to deepen your clinical self awareness and improve your ability to stay grounded and effective even when your own emotions are activated in session. We will begin with definitions, then move to real life clinical examples, go on to common pitfalls, and include practical strategies. We will especially focus on how these dynamics show up in treating depression and anxiety. So let's start. Let's define two foundational terms: transference and countertransference. Transference is when a client unconsciously redirects feelings and attitudes from someone in their past onto you, the clinician. They may relate to you as if you were a critical parent, a nurturing sibling, or an abandoning partner, or anybody else from their past. Now, this isn't always obvious, but it powerfully shapes how they interact with you. Countertransference, on the other hand, is your emotional response to the client. It may be a reaction to their transference or may be rooted in your own unresolved experiences. Countertransference is not inherently bad. It can offer valuable insight if you notice it, name it, and work with it. But if it goes unnoticed, it can distort judgment, blur the boundaries, and even erode the therapeutic alliance. Let me give you an example. So let's say you're working with Maya, a woman in her late 30s with a long history of sexual trauma. Over a few sessions, Maya begins idealizing you. She says, "I've never felt this safe with anyone." You feel proud. Then you might feel protective. And you might even feel a bit possessive. At that point, you might start bending your own rules, offering longer sessions, checking in between appointments, and you feel generous. But when you step back, you realize you're not just responding to Maya. You're responding to something in yourself. And that's countertransference. Maya's vulnerability activated your own history and your own longing to be someone's rescuer. That's where supervision and self-reflection are essential. Let's explore where countertransference tends to show up most strongly. We'll give a couple of broad examples. First, clients with trauma histories. When a client describes horrific abuse or deep emotional wounds, you may feel waves of protectiveness, sadness, or even fury. These feelings can lead you to overfunction, overpromise, or bypass the client's autonomy. For example, let's say Kevin is a 14-year-old in foster care after years of neglect and abuse. One session, he mentions that his current foster parent sometimes locks him in his room for hours, and your chest tightens. Rage rushes in. The moment the session is over, you call the Child Protective Services without fully assessing what's going on. Now, your actions may be justifiable and even correct, but your impulse came from your pain. And that's countertransference. So obviously, the goal isn't to suppress it. The goal is to recognize it and pause before acting on it. Another example might be clients with narcissistic traits. These clients might dismiss your insights, question your expertise, or dominate the session. I remember once I had a client, we'll call him Jordan, successful executive. He leaned back and scoffed. "You're not going to try that CBT stuff on me, are you?" I felt a sting. My first impulse was, look at all those degrees, the training. I've been in this for years. Stop. That impulse is a clue. At that point, he activated some insecurity or maybe some old feeling underestimated. Once I react, I'm no longer listening to him. I'm defending myself. Or maybe clients who are traditionally labeled as resistant clients, those who do things to struggle to improve. They're missing sessions, they shrug off the homework, they question your help, and it's tiring. After time, after working with them for weeks or months or whatever it is, you start to feel burned out. An example of this would be, let's say, Tanya, who has chronic depression, and she arrives late every single time, again and again. And through the session, I don't know why I bother, she says. And you find yourself saying less and less. You avoid eye contact. You start counting the minutes. Well, not at the watch because you have a clock behind her. But it's not her failure. It's a dynamic that comes between the two of you. Tanya's hopelessness might be mirroring something in your own feelings of futility. Again, here, reflect. Don't reflect from that place. Identify and work with it and work through it. Recognizing your own emotional blind spots is a very important part of this process. Because after all, therapists are not blank slates. We are human beings with histories, biases, wounds, stories, and sometimes our reactions in sessions have very little to do with the client and everything to do with us. How do you know? What is your sign that you are coming up against your own personal blind spots? Well, a couple of possible signs is like, for instance, you feel unusually tired after a session. Or you fantasize about rescuing a client. Or on the other hand, you might avoid a certain client altogether. Or you might suddenly find yourself bending accepted boundaries. You begin seeing Kevin, a quiet, withdrawn client. He reminds you of your emotionally unavailable father. You find yourself trying harder to connect. There's silences, and then you fill them up with nervous chatter. Or you might start to dread his sessions, not because of him, but because of what he brings up in you. And that's your blind spot. In other words, you might not even connected it with emotionally unavailable father, but these signs show that you have to look, and maybe that's what it is, because then therapy becomes a mirror. For the client, yes, but certainly also for you. So, why does this matter? And that goes straight into the idea of ethics and supervision. Why is it so important to understand countertransference? Well, because unrecognized countertransference compromises client safety. It leads to ethical risks, such as blurry boundaries or dual relationships, or even ruptures in trust. It erodes the therapeutic framework, the safe, predictable container clients rely on. So, for example, you're working with Lila, a 19-year-old who reminds you of your younger sister, but she's in a toxic relationship. And when she talks to you about it, you don't just feel concerned. You feel protective, righteous, and urgent. You gave her some homework and guidance of how to deal with her boyfriends when they're expecting something or another event to happen over the weekend, and you found yourself texting to her on that weekend, saying something, "You got this, girl," or "Don't let him win." Text him, "I'm here for you, always." The next night she calls you crying and you answer. She says you're the only one she can trust. and you reassure her that she can trust you. And you stay on the phone with her for nearly an hour. The next session, she doesn't talk about the relationship at all. She wants to know what you meant when you said always. And you realize she's confused. And truthfully, so are you. Of course, it started with empathy, rightful empathy, but without reflection, that empathy slid into enmeshment. Why? Because your own emotional history blurred the lines, and now she's not sure whether you're her therapist or friend or her rescuer. And truth of the matter is, you're no longer sure either. And that's why supervision is sacred. It protects the client and you from drifting off course. So let's talk a bit about working with the countertransference. How do you actually do that? What can you actually physically or mentally do? So let's talk about 4 essential tools. And we'll take our time with each one of them. Tool number 1 is mindfulness. Before every session, pause, take a couple of deep breaths. Ask yourself, how am I feeling right now? Am I bringing anything into this space that doesn't belong to the client? And then during the session, pay attention, scan your body. Do your shoulders tighten when they speak? Do your jaws clench? Do you feel heat in your chest? These bodily signs are messages because often the body knows what's going on before your mind catches up. Then after the session, take another breath. Notice what feelings linger. The goal is to become aware of them so you can respond rather than react. Another tool would be something we call clinical journaling, which is not the note-taking. It's a space where you can get honest, where you say, what came up for me here? What surprised me? Was this part of this interview that I felt irritated or pulled in or powerless or overconfident? Did I talk more than usual? Did I talk less and try to avoid something? Clinical journaling doesn't need to be eloquent. It don't have to write it well. It just needs to be true, honest, and genuine. And then the pages become a mirror. And over time, they reveal your patterns, which fosters your growth as a therapist and as a person. A third extremely important tool is supervision and consultation. Now, the word supervision in the world has a negative connotation or close to negative connotation because it seems to be connected with performance review. And if you have a performance review, you might be getting fired. So you want to make sure the supervision is going to be all nice and rosy. But that's not what supervision is in psychotherapy supervision. It's exactly the opposite. It's not a test. It's not your lifeline. It's exactly where you say something is happening in me and I want to understand it. It's where you bring your countertransference to supervision. And then you're not confessing failure. You're demonstrating integrity, honesty, genuineness. You can talk about the client you dread. You can talk about the one you over-prepare for. You can talk about the one who feels too familiar. And say it aloud. I'm afraid I care too much, or I'm afraid I don't care enough. A good supervisor helps you hold these fears and look beneath them, so you will react with them, understand them, and work on them to grow as a therapist and in truth as a person. The fourth tool are basically reflective questions, which you can keep on your desk, a short list, either on your desk or in the journal or someplace. Ask, am I responding to something in the present or the past? Or what unmet need of mine is getting stirred up? Another question you might have in your mind when you're writing this list is, if I had no fear of being judged, what would I say about this moment? Or what am I avoiding by overfunctioning? Or what would a neutral, grounded therapist do right now? And what I do is I put my notebook down and I write down a couple of words so I can remember what it was about, and then go back and ask the questions. But they don't have to lead to answers. They're not check boxes. They're just invitations. Now, the countertransfers can show up differently depending on the client's primary issue or diagnosis. So we're going to look at it a little bit more in detail when it plays out in anxiety and depression. So we'll start with anxiety, because clients with anxiety often bring intense energy into the room. They seek reassurance. They want answers. They fear uncertainty. And it's real easy to get pulled into a cycle of soothing. They can ask, is this normal? What if I'm going to lose my job? What if I die in my sleep? And naturally, you want to say, you're okay. Things will turn out fine. And sometimes you might say that, but over time, you start feeling really drained. Dread creeps in before the sessions. And when that happens, you start to feel trapped, as if you're carrying their anxiety on your own shoulders. You're not just treating it. That's your countertransference. Their fear has awakened your own, or perhaps a part of you that hates feeling powerless. So, for example, your client, Dana, has a panic disorder. Each session starts with, I thought I was dying again this week. She clutches her chest. Her voice shakes. And you feel it rising in your own chest. What do you feel? Along with that, the urge to make it stop. You hand her a breathing script. You list all the evidence that it's not a heart attack. If you're lucky, she calms down. But then you feel relieved, but also a bit exhausted. So you think about it. And you realize you're not just treating Dana's fear, you're trying to avoid your own. By realizing that, you're going to try something new. You would say something like, what was it like to go through that moment without trying to fix it? Suddenly she says, I'm afraid of dealing with this panic attack all alone. There's nobody there ever to help me. You feel all of a sudden the shift. It's a new, different type of therapy already. You're not fixing. You're talking about what's going on inside of Dana. Well, let's look at depression. So clients with depression will present themselves as hopeless, lethargic, and often self-loathing. Let's say you feel ineffective, or sad, or even irritated. So you try harder and you push for solutions. And if that doesn't work, maybe you disengage and you pull back. What's going on here? Let's give an example. So Mika, 29-year-old, says, there's no point. I don't want to get better. You offer your good CBT tools. You suggest behavioral activation. Mika shrugs. After the session, or better yet, session after session, you start feeling more and more helpless. And you start thinking, I'm not making a difference. And you start watching the clock. Well, not that clock, because that's too obvious, but the clock behind the client, which you always have. And you're watching it. So this too is countertransference. Mika may be touching on your fear of failure, or your pain of watching someone suffer who won't reach out for help. Now that you've thought about this, you realized where your reaction is coming from. Instead of pushing, you sit back and you say, it seems really hard to believe anything can change. Oh, in conclusion, so where does this leave us? Well, countertransference is not a flaw. It's not a sign of incompetence. It's a signal. It says, there's something alive here, something important. Pay attention. You're not a machine. You're not a blank slate. You're a human being sitting with another human who's in pain. And that means sometimes your own pain will get stirred. Your task is not to silence it, but to understand it. And when you do, your work becomes deeper, clearer, and more precise. Make no mistake about it, the clients feel it. They know when they're being heard through a fog, and they know when they're being seen clearly. And when you take responsibility for your own emotional process, they learn to do the same. It's a mirroring process where you teach them by example. And this is the sacred loop of healing. You reflect on your story so they can find theirs. You step back when needed so they can step forward. And you get supervision so you can hold them without losing yourself. It's not easy. I won't tell you it's easy. It's a lot of work. But it's worth it. And in truth, all your clients, and I also, thank you for committing to this work, for committing to your growth, your insight. I thank you for your courage and your capacity to sit with discomfort and still choose compassion. This is the work of transformation. And in truth, you are right where you need to be.